Thanks for joining us. I'm Dr. Ron Yee, family physician, and I have the privilege of serving as the Chief Medical Officer for the National Association of Community Health Centers. Million Hearts is committed to preventing 1 million heart attacks and strokes. And as Million Hearts 2027 begins its launch, it's important to note that one of the priority areas is health equity. In the December 6th edition of the Circulation Journal, a research letter cites work that began prior to and continued during the pandemic. The study highlighted elevated blood pressures in the group during COVID that were previously stable in the 2 years prior or pre-COVID that will require follow-up post-pandemic to assess the permanence of these blood pressure increases. Public health interventions reinforcing the need to address chronic medical problems, even during a crisis, remain crucial. The pandemic uncovered and brought focus to health disparities that worsened. As one of the priority areas of Million Hearts 2027, we'll spend some introductory time today on health equity and disparities, and then we'll take a deeper dive during our January 2022 Million Hearts Learning Lab. So I'd like to turn over to Yvonne. And Yvonne, can you share some data on cardiovascular disease disparities and social determinants of health?
Yes, thank you, Ron. Hi, everyone. My name is Yvonne Commodore Mensah. I'm a nurse and cardiovascular disease epidemiologist at Johns Hopkins Schools of Nursing and Public Health. I'm happy to provide an overview on what we know about cardiovascular disease disparities in the US. So despite overall declines in overall cardiovascular disease mortality, we know that racial and ethnic minority groups disproportionately suffer from cardiovascular disease and mortality from cardiovascular disease. In 1968 to 2015, the Black-white disparity in cardiovascular disease deaths actually increased by 16.3%. And we also know that Black people continue to have the highest rates of CVD mortality, CHD mortality, and stroke mortality compared to all other racial and ethnic minority groups. Next slide. The greatest disparity that we see is in hypertension-related mortality, where Black people have the highest CVD deaths that are related to hypertension. You can actually see that wide gap between Black people and white people on the left side of the screen in the hypertension panel. So what explains these preventable racial and ethnic disparities in hypertension and other cardiovascular outcomes? So there's greater appreciation now that race is a social construct. However, social determinants are the root causes of these disparities. So social determinants have been defined as the structural conditions in which people live, play, learn, work, pray, or grow. And these pertain to the built environment, the neighborhood, economic opportunities, policies in our environment, in our social conditions. Sorry, I'll restate that. So these relate to a neighborhood and built environment, also economic policies, opportunities that are available to racial and ethnic minorities. But we also know that community health centers are addressing these social determinants. And so, Ron, I'd like you to share, what are community health centers in the country doing to address these social determinants and prevent cardiovascular disease?
Sure, Yvonne. You know, when I think of health centers and addressing social determinants of health, one of the first things that comes to mind is the provision of what are called enabling services. And these include things like transportation, translation, health education, and health insurance enrollment assistance. All health centers provide these services which address various social determinants of health. You know, many health centers like Lawndale Christian Health Center in Chicago, Illinois, and La Maestra in San Diego, California, address food insecurity, specifically impacting cardiovascular disease, diabetes, and obesity by providing healthy fruits and vegetables coupled with cooking and nutrition classes. And clinicians actually write prescriptions, which they call food as medicine, like Jack Geiger, the father of the health center movement, prescribed. In Chicago, they call it the Veggie RX program, and the Jardín de la Vida, or Garden of Life, in San Diego. Patients pick up their crate of healthy food each week from the health center's farmers market. El Rio Health Center in Tucson, Arizona worked with their managed care company to run reports on patients who have high-risk cardiovascular conditions and risk stratify these patients for possible ER visits and subsequent hospitalization. And they proactively manage these patients by providing 24/7 nursing triage protocol line, same-day appointments, and medication refill protocols to prevent cardiovascular events. Now, patients discharged from the hospital, should they be admitted, post-MI, stroke, or hypertensive crisis, are provided with concrete, detailed plans even before they're discharged. They go home with proper medications, home health support, devices, transportation, and an understanding of the discharge plan that includes a follow-up visit within 7 days and telephone call reminders. A coordinated multidisciplinary team of clinicians, pharmacists, behavioral health, community health advisors, and RN care coordinators manage medications, care, and follow-up. And the hospitalization rates went down by 11% for their Medicaid population and 9% for Medicare in just 6 months. Family Health Centers of Southwest Florida, known for their hypertension algorithms, medication intensification, and provision of affordable medications, address different aspects of health equity. They've got it down to a science where they know they can get a patient under good hypertension control for a nominal monthly cost in a very short period of time. And one other success story that just came up is from an uninsured Somali patient at International Community Health Services in Washington. On her first visit, she was diagnosed with hypertension, diabetes, hyperlipidemia, and had major transportation issues. Because of the health center's hypertension protocols and enabling services, she was provided transportation, dropped 10 pounds, her blood pressure was brought under control, and her A1C went from 8.0 to 7.3 in just 5 months. And she was so proud of her ability to lose weight, monitor her blood pressure at home, and to be an active participant in her own care. Yvonne, these are just all health center examples that address health equity and social determinants of health to prevent or manage cardiovascular disease. So Yvonne, tell me about nursing as part of the care team. Can you talk about the role nurses have in cardiovascular disease prevention?
Well, Ron, I think you provided two great examples. One of them was a triage line that was managed by nurses, and nurses helping patients with managing their medications. So there are over 4 million nurses in the US, and each nurse has a pivotal role to play in improving blood pressure control. So there's actually a nursing work group that has been developed in response to the Surgeon General's call to control hypertension. And the role of this group is to coalesce to understand how to mobilize nurses to actually put to action some of the recommendations that are made in the call to action. So with respect to health disparities and how nurses can advance health equity, there are a number of different roles that pertain to registered nurses, advanced practice nurses, quality improvement nurses, and population health nurses. Some of them include, one, assessing and addressing social determinants. Like I said earlier, social determinants are key drivers of these cardiovascular disparities. Quality improvement nurses and population health nurses can actually probe and evaluate data for community health centers to understand where are the gaps and where are the disparities, for instance, in blood pressure control, and what can be done about it. Other examples include nurses and nurse scientists actually going out into communities where people live, learn, work, and pray to implement community-based programs to improve cardiovascular health. And examples of this may include faith-based settings, barbershops, salons. There's an abundance of evidence that these settings are ideal, but there are really gaps in terms of how we might implement these strategies. And nurses can contribute to these efforts nationally. So nurses are just one segment of the healthcare workforce, but they're also pharmacists. So Ron, I'm sure you have great examples of how pharmacists can also contribute to improvement in hypertension control and promoting cardiovascular health. Any examples that come to mind?
Yes, Yvonne, thank God for nurses, but health center pharmacists play a critical role in cardiovascular disease treatment and management. And in our Million Hearts project, they've concentrated mainly on medication adherence, intensification, and comprehensive medication management. And one great example is Philadelphia Fight, one of the health centers in our learning community, was recently chosen as a Million Hearts exemplar organization. They reached out to patients with hypertension, focusing on medication adherence to achieve blood pressure control during the pandemic. The pharmacists teamed up with other health center staff, and if patients weren't able to receive at-home delivery of their medications through their retail pharmacy, staff members personally delivered them. They called over 5,000 patients, delivered medication to over 600, and also helped an additional 1,200 patients manage medication concerns. They had quite the impact on cardiovascular disease management amidst COVID-19. So Yvonne, can you provide us with some concluding thoughts as we conclude our time here together?
Yes, I would say that the focus on health equity is timely. The COVID-19 pandemic has reminded us of the need to ensure that everyone has timely access to healthcare. We've all seen the disproportionate suffering that racial and ethnic minority communities have experienced as a result of the COVID-19 pandemic. But we also know that heart disease remains a leading cause of death. So as we think about how to mitigate the impact of the COVID-19 pandemic, we should not forget that cardiovascular disease actually increases the risk of hospitalization and deaths from COVID-19. We need to ensure that all patients continue to have access to primary care providers, either using telehealth or finding other safe modalities to deliver care virtually. So, Ron, what are your thoughts about how we can all act in terms of implementing policies in collaboration with the National Association of Community Health Centers to advance health equity?
Sure, Yvonne. You know, for the past 50 years, health centers have been at the heart of addressing social determinants of health disparities and health equity. And they find practical solutions with a strong evidence base and data that supports their work. And we've really just scratched the surface on data that tells the story and innovation occurring in health center field. But in terms of policy, I think we're trying to work closely with payers and CMS to look into things like reimbursement for home blood pressure monitoring, remote patient monitoring, looking at reimbursement for all the testing that's necessary and follow-up and telemedicine, of course, that you mentioned. So we're looking at audio visits, all the things with telemedicine that can support our health centers in what we have uncovered in the Million Hearts Project that really supports good patient care. So I think we go at the operational level, but also policy and payment to round out our approach. So we'll dig deeper into these topics. We'll hear from other subject matter experts and from our colleagues in the health center field themselves during our January 19th Million Hearts Health Equity Learning Lab that'll run from 3 to 3:45 p.m. Eastern Time. And again, Devon, thanks so much for this introductory discussion, and we hope you'll all join us for our Learning Lab in January.
Thank you, Ron. It's been a pleasure.
Thank you.
All right.